This conference will now be recorded.
Okay. Question number 8. Which of the following has the highest sensitivity to diagnose pre-labor rupture of the membranes? Okay, like that. So here they didn't give you amnisure. If they give you amnisure, that will be your answer. Okay. So no amnisure here. So we will find out this pelvic exam. Okay. Basically, amnisure, that is 99%, 99% accurate. It will tell you it has very high negative predictive value, that it is, if it is negative, then patient is not, didn't have this premature rupture of the membranes. That is one thing. So two ways to diagnose fetal, like if you're going to do the test, you can do that in two tests. Okay, you can look for the amnisure, you can do that one, or then you can look for the fetal fibronectin. So fetal fibronectin, if it is more than like 50 nanograms, then it means that this patient is going to deliver in the next 7 days. That is the chance. Okay. So question number 9. Pregnant patient presented with a preterm pre-labor rupture of the membranes. Then she developed maternal fever and palliative tachycardia. So what is the most likely causative organism? Okay. So this is basically chorioamnionitis. All organisms, mostly they are coming from the your own environment. But here in this case, which one is associated with the highest chance of this this chorioamnionitis? That is group A beta hemolytic streptococci. That is the one. Okay. Then remember the risk of chorioamnionitis with the intact membranes, that is 0.5%. And the risk of chorioamnionitis with rupture of the membranes, it is going to be 1%. But maternal complications can be there. Mother can develop PID, mother can develop PID, she can develop like subclinical infertility due to the tubal disease, because there will be infection. Okay, so that's why it is very important. So if there is tubal infection, then the chance of developing an ectopic pregnancy in the future, it will increase. Okay, so higher chance of developing this ectopic pregnancy, recurrent ectopic, and high chance of having this tubal factor infertility and PID. Then another important manifestation, it can be like there is chorioamnionitis, there can be PID, she can go into sepsis. All of these are very important. Okay, that is one thing. So then what should be done? Like she's this one, how many weeks she is, they didn't tell you. So if she is at 27 weeks, the first step in the diagnosis in the treatment will be antibiotics for the 48 hours. Like you should give ampicillin for 48 hours, and then you should give, and this will go intravenous. Okay, if the patient is sensitive to ampicillin, you can give them what can be given, cefazolin. Okay, if sensitive to cefazolin also, then you can give vancomycin. Clindamycin not given anymore, because 16 to 25% in the resistance, so that's why we don't want to give it anymore. We can give erythromycin 250 milligrams 4 times daily for 10 days, and then we have to stop after 10 days. Augmentin, I made it red because it can cause necrotizing enterocolitis, so we will not give augmentin. So the complications of and the preterm labor, there can be respiratory distress. With preterm, baby is going to have many complications. Okay, and if they will give antenatal corticosteroids, we will decrease the chance of necrotizing enterocolitis by 33%, chance of respiratory distress syndrome by 44%, and we will decrease the chance of intraventricular hemorrhage by 46%. Why this baby will have hemorrhage? Because the bones are small, delicate, so when it will go through the maternal birth canal, the baby is going to have intraventricular hemorrhage also. Then we need to give magnesium sulfate for neuroprotection. It will decrease the chance of developing cerebral palsy. Even if cerebral palsy will develop, it will not be very severe. So we need to offer induction of labor, and you will offer cesarean section only if induction of labor fails. Like, okay, if induction of labor is not successful, then we will go for the cesarean section, and then you should know that what should be done at delivery. At delivery, and the neonatologist should be present, and they should be, senior consultant should be present, like senior registrar or the consultant should also be there, so that they can see that what exactly is the problem. And then the baby should be in the NICU. If you don't have a bed in the NICU, then you need to see that the patient is close to delivery or she is far from delivery. If she is far from delivery, you will do in utero transfer. But if the delivery is imminent, like she is likely to deliver the baby now, then we will deliver her and then ex utero transfer to the new place. Sometimes they will ask you who will inform the next hospital. Your answer is that I will inform. Why? Because if you will just leave the patient, then it is going to be bad. So you need to tell them that we are going to send the patient ourselves. I will inform the next consultant. It is your duty to ensure that everyone has got the message, because preterm baby, unfortunately, they can have many problems. So that's why very, very important to refer them yourself. That is important thing. Then question number 10, a pregnant patient with history of previous 2 cesarean sections, bariatric surgery, presented with abdominal pain, fetal heart is reassuring. So what is the most likely cause? Abdominal pain. So the most common cause is going to be like bowel obstruction. That is one thing, okay? That is the most bowel obstruction can be in different forms. They didn't give you the most common cause. It can be maybe bowel obstruction is the one that is the most common. It will depend upon the time when she has presented, okay? Like the surgical complications, they will depend upon the time when they have presented. If she has presented within first 24 hours, most commonly atelectasis. On day 2, most common infection, pneumonia. On day 2, the second most common infection, UTI. Day 3, chance of VTE. Okay, day 4, the wound infection will start. Day 5, there is chance of the venous thromboembolism. Okay, all of these things should be in your mind. What is the most common complication of the cesarean section in the post-op period? Your answer is paralytic ileus. Why? Because 12% patients, they will have paralytic ileus. What is the treatment of paralytic ileus? We discussed in detail when we were doing 2020 records. Question 11. Bandel ring is associated with which of the following? Bandel ring is associated with obstructed labor. I showed you before in the obstructed labor what will happen. It will be narrow in the center and it will be like dilated above and below this narrowing point. That is the point, okay? So here also we will look at this picture. I think we saw the same picture before. This is a Bandel's ring, okay? Like this one, okay? You can see it from the outside also. Here also look at this one. This is the Bandel's ring, okay? So this is a Bandel's ring. So what has happened? The baby is there. There is the like uterus in the upper part, the baby, in the lower part, the bladder. And the lower part is also like dilated, okay? So we are going to see the Bandel's ring in the between the upper and the lower part of the uterus. Here it is. Like you will look at this one and you will see. Can you appreciate it? It is narrow here, okay? A broad above, broad below, and this is a Bandel's ring. That is one thing. Like this one, this is the constricting ring, okay? So this is a Bandel's contraction. It will be abnormal. So associate, it may increase the risk of having a ruptured uterus. So that's why important to remember that these points, okay? So that's what can happen during labor like that, okay? Right, came to this one. So that is Bandel's ring, okay? Bandel's ring, we are going to see that where if there is obstructed labor, that is one thing, okay? So important to remember because there can be ruptured uterus. So that is associated with obstructed labor. Woman is contracting, but the baby is not going out. Question 12, a pregnant patient who is HIV positive came for antenatal care at 36 weeks. She is on Zidovudine prescribed from from another hospital and her viral load is 1000 copies. So what is the appropriate management? So this one, So she's on single dose therapy. So at this high level of the viral load, there is no concept of single dose monotherapy. So we are going to offer her combined HRT, so right, CART, combined antiretroviral therapy. And what we have to do, like she has 1,000 copies, so we need to switch to the combination therapy, and we should do cesarean section at, actually we should do at 39 weeks, but here the problem is they are telling you continuous zidovudine. But single dose is not good here. We need to give her combination therapy, and then you can deliver her at 38 weeks. That is one thing, okay? Because the viral load is very high, so she should be on the combination therapy to suppress the viral load like that, okay? So for the spontaneous vaginal delivery, she should have like viral load should be like 400 copies per ml or less than 400 copies per ml, and the CD4 count should be less than, the viral load should be, CD4 count should be like 350, and the viral load, it should be less than 50 copies per ml for the SPD. That is one thing, okay? SPD viral load should be less than, 50 copies. So there is some difference. In the American system, if they will give you, they will say that even at 1,000 copies, you have to, you more than 1,000 copies, you will go for the, cesarean section like that, okay? But mostly they are giving the benefit to the patient, so they are asking this question from the British guideline. Then you should know about the opportunistic infection. Like CD count is less than 200, you need to improve the control of the antiretroviral therapy like that, okay? So if it is like this one is like 100, CD count is 100, then you have to think about the mycobacterium. Then you have to think about the toxoplasmosis, and you have to think about the aspergillosis and Pneumocystis carinii. Now, in the new guideline, we don't give any treatment for the Mycobacterium avium. We will not give anything, okay? But for the toxoplasmosis and for the toxoplasmosis, you will have to give the prophylaxis, and you also need to give the prophylaxis for the Pneumocystis carinii. Luckily, for both, the treatment is going to be sulfamethoxazole and trimethoprim, that is Bactrim tablet or Cefton tablet. If the CD count is less than 50, you need to give them cytomegalovirus, and you need to give them herpes simplex virus like that, okay? So then another question they would like to ask you, when are you going to test the BB? You are going to test the BB at 2 days, 2 weeks, 2 months, 6 months, 1 year, and then 18 months. Another question, when can you tell the parents confidently that the baby doesn't have HIV infection? Your answer is at 18 months. Why? Because at this stage, all antibodies from the mother, they will be clear. They will not be in the system. So the baby will be showing you his own immune response. Question number 13, it says, a pregnant patient at term presented after 21 hours of membrane rupture. She didn't have any antenatal follow-up. So rupture membrane was confirmed by pelvic exam, and she is having 2 contractions in 10 minutes. She is afebrile, stable vital signs, and she fetal heart rate is reassuring. So what is the most appropriate action? So mother is your primary patient, so you are going to give antibiotics to the mother. Why you want to give her antibiotics? Because you want to prevent her from the chorioamnionitis. Okay, chorioamnionitis. Why? Because she can develop subfertility. She can develop like the tubal factor infertility. She can develop PID, increased chance of ectopic pregnancy, and that's why we need. And she can develop chronic pelvic pain. So that's why we need to give her GBS prophylaxis, because that is the most suitable. Other things maybe they didn't give. Why GBS prophylaxis? That is also correct, because that is the #1 cause of early neonatal disease. So correct answer is start antibiotics for GBS. Question 14, a pregnant patient diagnosed with fetal death with foul smelling vaginal discharge, placental microabscesses. So what is the most likely causative agent? Listeria. Okay, listeria is the most common causative agent of such problem. It can cause sudden IUFD, and then it will cause you, where is the clue? These placental micro abscesses. We talked about it. How she is going to get it? From the soft cheeses, from the milk and the other dairy products. So she should not be taking this stuff, okay? And what is the treatment you need to give? What you need to give? Amoxicillin. For how long? 21 days. Give amoxicillin for 20 days and 21 days and she's going to be fine. So funicitis. What is funicitis? Funicitis is infection of the umbilical cord and placenta. So that is placental micro abscesses. Small abscesses are forming because of the listeria. Question 15. A pregnant patient presented to antenatal care at 23 weeks. Her fasting blood sugar was high. Hemoglobin A1C was also high. So what is the most likely diagnosis? Okay. So HbA1c is high. At how many weeks? At 23 weeks. This is confusing, right? Because she has come to you at 23 weeks. But HbA1c, it is going to tell you that how is the sugar control in the last 3 months. Okay. So last 3 months means that the sugar level was higher at less than 20 before 20 weeks of gestation. So this patient already had pre-gestational diabetes. Okay. It has not started because in the gestation diabetes it has to start after 20 weeks of gestation. But HbA1c, it is telling you about the control over the last 3 months. So this one has pre-gestational diabetes. Question 16. Pregnant patient presented with this picture. So what is the diagnosis? So that was melasma, because she had like many patches on her face like that. So that was melasma. So let me pull out that one.
This conference will now
So
be
the answer
recorded.
was melasma of pregnancy if you have pigmentation. Okay, if you have like small spots on the face, then you will say that this is miliary rash. So then question 17, pregnant patient had tetralogy of Fallot repaired during the childhood and she has no limitation at rest. So when she walks from her car to work, she has minor complaints. So which New York Heart Association classification she belongs to? So basically we have like 4 classifications, 4 grades, like there are 2 classifications, okay? What is the functional level and what is the level of the on the basis of the symptoms, okay? Class 1, patient has structural myocardial change. For example, she has left ventricular hypertrophy, okay? 2, small decrease in the exercise tolerance. 3, significant decrease in exercise tolerance. That is one thing, okay? And 4, symptoms of heart failure in rest or during small exercise. During little exercise and she will be symptomatic. At 1, she will have no limitation of activity like that. Like the structural change is there, but it is not symptomatic. Can be, cannot be like that. So the doctors usually classify patients' heart failure according to the severity of their symptoms. And it depends that what is their functional level, okay? So it is based on the patient symptoms. Class 1, so they will give you the symptoms or they will tell you about the limitation of the activity, so you will have to choose from there. So what is the patient symptoms? Okay, class 1, no limitation of physical activity, and ordinary physical activity doesn't cause undue fatigue, palpitation, dyspnea, or shortness of breath. 2, slight limitation of physical activity. Patient is comfortable at rest. Ordinary physical activity, it will result in fatigue, palpitation, dyspnea, which is shortness of breath. Dyspnea is shortness of breath. Class 3, marked limitation of physical activity, comfortable at rest, less than ordinary activity, it will cause fatigue, palpitation, or dyspnea. Like she is just moving about the room and she is becoming symptomatic, okay? So we will say this is New York Heart Association class 3. Class 4, patient will be unable to carry on any physical activity without discomfort. She cannot do anything, she will do something and she will become symptomatic. Symptoms of heart failure at rest. If any physical activity is taken, discomfort will increase. This is the subjective assessment. Subjective assessment, how the patient is describing her symptoms. Now the objective assessment. What is the objective assessment? What you did in the to assess the condition, you have done some test. What is your assessment? Okay. Class A, no objective evidence of cardiovascular disease, no symptoms and no limitation in ordinary physical activity. B, objective evidence of minimal cardiovascular disease, mild symptoms and slight limitation during ordinary activity, and patient is comfortable at rest. Class C, objective evidence of moderately severe cardiovascular disease, marked limitations in activity due to symptoms even during less than ordinary activity. This patient is comfortable only at rest. Class D, objective evidence of severe cardiovascular disease, severe limitations, and experiences symptoms even while at rest. For example, these are the examples. So the purpose is that a patient with minimal or no symptoms but a large pressure gradient across the aortic valve, or they have like obstruction of the left main coronary artery, we will say functional capacity 1, objective assessment D. Why? Because this patient has limitation of activity. But this is beyond your scope, okay? Just remember how many types of assessment we are doing. 2, subjective, what the patient says, okay? And then objective, how do you know about, what do you say about the disease? What is your assessment? Here I will tell you some interesting thing. They will give you a patient, okay? They will ask you, what is the first test to do? Write it down, okay? If the patient has pain, chest pain, you will say that this is myocardial infarction or this is acute coronary syndrome. So what test should be done? Patient has ischemia. So when will you see the ischemic changes? Ischemia means less oxygen for your patient, okay? If you suspect that patient has myocardial infarction, just request ECG will be the first test. Always ECG, ECG, ECG. In the acute setting, patient has come to you suddenly with the myocardial infarction. So what is the problem? So you will do the ECG. Now they give you another patient, okay? Patient has come to you from they will usually what they will tell you. Patient has come from India, patient has come from Pakistan, she has come from Gulf, she has swelling of feet, she is young patient, she has palpitations and she has this. So I mean she doesn't have chest pain. She will have everything but she will not have any pain. What will you do for that patient? So you will say that this patient has mitral valve. He has some valvular problem, okay? So you will say that this patient has some other problem. She has some heart related problem like that, okay? So she has valvular problem. So if there is problem in the valves, which test are you going to do? You will do echocardiography. Okay, you will do echocardiography. Don't go into the detail. Everything is present in the maternal medicine, but just remember the main points, okay? If you suspect any valve lesion, like the mitral stenosis, something is there, aortic stenosis can be there can be mitral valve prolapse. Yeah, I mean, any valve problem, you will do echocardiography. Any chest pain, you will do ECG. That is one thing, okay? So what is the incidence of having myocardial infarction during pregnancy? Write down 4 to 12%. That is one thing. Okay. Different presentations can be there, like just now I told you about it. Patient can have, like, you will look for she can have heartburn, shortness of breath, or she can have other pregnancy symptoms. Okay. And you should be considered in the differential in cases of the chest pain. Remember, cardiac disease is not the most common cause of chest pain. The most common cause of chest pain is heartburn. Patient is pregnant or not pregnant. The most common cause is heartburn. Okay. So if heartburn is excluded, your patient is good. Then you will look for the risk factors. What are the risk factors? Hypertension, diabetes mellitus, smoking, preeclampsia, thrombophilia, she has received transfusion, she has postpartum infections, and she is multiparous. Multiparous, more chance of having what? More chance of having peripartum cardiomyopathy. Okay. Don't go about the details because it is too late to do that thing. Okay. But ST segment elevation will be there. Okay. ST segment elevation where it will be in lead 3, lead 2, lead 3. Okay. If it is in the lead 2, 1, 2, or 3, then you will say this is for the left heart. This problem is from the left ventricle. Basically, left heart means left ventricle. If there is change in V1 and V2, it can be seen in normal pregnancy, but it can be like because of the right ventricular injury. V1, V2, remember, for the right ventricular injuries like that. Okay. Sometimes ST segment can be elevated, that is the most common presentation. Okay, but sometimes the ST segment can be depressed also, which will tell you about myocardial ischemia, and that is one thing. Okay, so then cardiac enzymes are very important. They will ask you which is the first enzyme to test. Your answer is cardiac troponin. Okay, cardiac troponin. That is the first thing. Which troponin? Troponin T. That is the first thing you are going to do. Check it. Okay. Then they will tell you, ask you another question. Okay. Patient had heart attack last week and the serum troponin was positive. So you treated her and now she has come back. She has similar problems. So what is the cause? What will be the test now? So the clinical picture will be that of the myocardial infarction. Okay. Can be young patient, can be old patient, can be someone after hysterectomy, something like that. But they will ask you mostly about the pregnant patient. Okay. So this cardiac troponin, you should remember, they will, once they are elevated, then they will stay elevated for 2 weeks. Okay. And now you are suspecting that patient has developed an other heart attack. So then you will go for the CKMB. Why CKMB? CKMB, it will appear within 4 to 6 hours and then it will remain elevated for 1 day or 2 days. Then it will disappear. Okay. So first time the patient had heart attack, so it has not disappeared because your patient is coming back at the 14th day. But this cardiac troponin, it will be elevated. So in that scenario, you will do the CKMB. That is one thing. Okay, because it will tell you that this is a new heart attack. Okay, and you are doing the test, these tests, if you are suspecting myocardial infarction or you are suspecting angina, like they will give you the history of some patient. Okay, and basically the ST segment can be elevated, ST segment can be depressed, or ST segment can have no change. Okay, but most common pattern ST elevation. That is one thing. So that is all about the acute coronary syndrome or about the myocardial infarction. Now echo. When you will do the echo, when you want to see the wall motion. When you want to see the wall motion will be normal if patient didn't have any myocardial infarction. If they give you someone where the cardiac wall motion is abnormal, you will say that this is because of the previous myocardial infarction, like that. Okay. So this is the set. These three things. The ECG is done in the acute setting. Echo is done in the outpatient follow-up. So it is never done for the acute case because the acute one is already dying. So what is echo? Echo is the ultrasound of the heart. We are not going to do that in the emergency. Then another test, exercise ECG or the stress test, you will do only if the patient is coming for the follow-up or if the patient has risk factor. If the patient has acute myocardial infarction, you will never do this exercise tolerance test because you will kill your patient. So it is very helpful, but you should remember that it may be like inconclusive at all in many cases, okay? So if the patient doesn't have acute pain, then exercise this ECG you can do during pregnancy also. Why? Because you will have to do it, but what will you do during pregnancy? You will have to monitor the fetus, you will have to monitor the mother also. You will evaluate both. Basically, I have told you ECG is good for the acute presentation, like if your patient has acute myocardial infarction. Okay. Echo, basically you are doing for the valve lesions. Remember in OGYN, you are going to see the mitral stenosis all the time. Okay. If the patient has no history and now she has developed some problems suddenly, write down. That is mitral valve prolapse. First presentation during pregnancy, in 80% cases, it will be mitral valve prolapse. Where is the mitral valve? Mitral valve is between the left atrium and left ventricle. That is the thing, okay? Cardiac catheterization. What is cardiac catheterization? You will just enter the balloon and it will tell you what is the size of the valve, okay? So that it is safe in pregnancy, it can be done. So what we have to do, we should cover the abdomen of the patient to prevent the patient from fetal exposure to radiation. That is one thing, okay? So what is the chance of having the like this radiation? Less than 10 rads, usually 8 rads, okay? If it is less than 10 rads, then no problem for the baby. But if the exposure is more than 15 rads, then it is going to be high risk for the fetal harm, like there will be bone marrow dysplasia, there can be childhood cancers, okay? And it should be done in the pregnancy only if it is urgent. Otherwise, it should not be done. Basically, they will give you a patient whose ejection fraction is very low. So what is the ejection fraction? How much the blood the patient is pushing in the circulation. So how much is coming out from the heart in each second, like that, okay? That is the ejection fraction. So usually these things are not done in pregnancy. Cardiac catheterization, you are going to see what is the size of the valve and do we need to replace the valve? That is one thing, okay? Nuclear imaging, usually we are not doing it during pregnancy unless it is very urgent. Again, you will have to do there can be fetal growth restriction because usually once the fetus has developed and the exposure to the radiation will result in IUGR. So that's why you have to be careful. And then the cancers like that. Okay. So all of these things you don't have to do. Okay. Angiography is gold standard, usually not done. Why? Because the coronary artery is already fragile during pregnancy, so there is risk of coronary artery dissection. That's why we don't do it. So then they will like to ask you about the complications. Just remember there can be heart failure, there can be ventricular arrhythmias like supraventricular tachycardia or ventricular tachycardia. Then patient can have recurrent heart attack or angina, all of these things. Okay, patient can develop ventricular fibrillation, and then patient can develop cardiogenic shock, patient can develop sudden death. All of these things can occur like that, okay? Fetal mortality rate 5% if the mother will die like that. Treatment multidisciplinary team, she should get the best treatment. So then they like to ask you which one is going to be life-saving. So these are life prolonging or the mortality benefits. Salicylates, aspirin, beta blockers, and then nitroglycerin, calcium antagonist, and heparin. Okay, and then the best therapy we don't know. So the best thing will be to give IUG, this aspirin. Okay, if we will give very high dose, it is associated with fetal death, IUGR, salicylate intoxication, bleeding, and then there can be premature closure of the ductus arteriosus. These things are important for you from the OB viewpoint like that. So these are the things that we need to remember. The patient will basically, you will send her to the to the cardiologist. Okay, don't go into the details of the entire. Just remember that many things like nifedipine can be used, but we don't have any other things like the verapamil and the diltiazem. They can have like small in the small studies with diltiazem, there is evidence of the congenital abnormalities. But the verapamil, yes, it can be given in the supraventricular tachycardias, in the ventricular tachycardias. Okay. ACE inhibitors and ARBs, they can be given. ACE inhibitors like captopril, lisinopril, and angiotensin 2 receptor blockers, losartan, these things, you know, that these are contraindicated during pregnancy. Important for you to remember. If you need to give, usually when your patient will have, you know, the VAM lesions, they will take diuretics. Why? Because if the blood volume is decreased, then the cardiac function will improve. Okay, that is one thing. So revascularization procedures, they can be done only if high risk, but they will never ask you. Just remember all of these things can be done. What is important for you? What will you do during labor and delivery? So remember, if your patient has right ventricular failure, okay, like I said, the changes were in V1, V2, then you need to give her fluids during labor. Okay, all other patients with cardiac disease, you will have to restrict fluid. Why? Because you don't want them to have overload heart failure. Okay, so delivery should be postponed if possible for at least 2 weeks after acute myocardial infarction. Maternal mortality is significantly higher during this time, possibly due to increased hemodynamic requirements during labor. Route of delivery, it should provide the least hemodynamic burden, and CS is only performed for obstetric indications as a vaginal delivery minimizes stress. Earlier reviews have suggested that higher mortality with the cesarean section, but more recent views, they said that there is any route is okay, no barrier. Okay. If vaginal delivery, then assistance during the second stage is recommended. What will be the assistance? Mother should be placed in the semi-sitting or left lateral decubitus position and provided with supplemental oxygen. Maternal monitoring should include ECG, pulse oximetry, and a CTG, continuous CTG. Okay, IV line arterial catheter and the pulmonary artery catheter should be considered if left ventricular function is significantly impaired. Early continuous epidural is recommended to minimize pain. Remember, the pain can also start myocardial dysfunction. But you should remember that if you are citing epidural, you need to give oxygen to the mother. Okay. Tachycardia and hypertension, if they occur, there you will need to call the cardiologist immediately, or the anesthesiologist should be there. Then how you will give assistance in the second stage of labor? You will offer planned operative vaginal delivery. That is your answer. Planned instrumental vaginal delivery. Now tell me, you have a cardiac patient. You will like to apply forceps or you will like to apply vacuum. What are your thoughts? Forceps. Forceps. Excellent. We will apply forceps because for forceps we don't need maternal efforts. Maternal efforts mean that mother will have to push with the contraction. So this action is not required for the episiotomy and for with the forceps delivery. So if the patient has heart cardiac disease, you will cut it to the second stage short by applying the forceps. But you will not apply the forceps in class 1 or class 2. Okay. Patient has class 3 heart disease or class 4 heart disease, then you are going to apply the forceps. That is one thing. Why you will not apply vacuum? Because the mother will have to push, which will increase the burden on her heart. Okay. So tachycardia and hypertension should be corrected. And in the third stage of the labor, we will not give ergot alkaloids. Which are the ergot alkaloids? Methergine or symptometrin. We will not give because they will increase these are vasoconstrictors, okay? So they will increase the risk of coronary artery spasm. So after initial recovery, the patient should be monitored for 48 hours postpartum in coronary ICU or general intensive care due to the significant hemodynamic changes that will occur at this time. So what significant changes will occur? Like more than 500 ml of the blood, usually 600 blood from the uterus, it will enter the maternal circulation. So it will increase the burden on her heart. That's why it is very, very important to know about the management of heart disease during pregnancy. These classifications like subjective and objective, these are very important for you for the exam, but more important because you can save life of one patient during labor in your care. So these things are important, okay? Then what else you should know about the cardiac patient? If he is at high risk of developing some disease, some cardiac disease, like some MI or fluid overload, but she's at high risk of having this PPH, then what you will do? You will take 100 ml normal saline, put 40 units oxytocin in it and run it at a very slow rate. You need to run it 40 ml for 4 hours because you want sustained contraction of the uterus. Now the question number 17. This patient's Fallow's pathology was repaired during childhood. So she has no limitation at rest. So when she walks, so what is the class 1? Because the class 1 means that your patient has some structural abnormality, but she's not symptomatic like that. Okay. So now I understand you have to go for your other class. So I think we can stop now.